Hello, everybody, and welcome back to my YouTube channel with a new and interesting presentation. Now, which is called double defibrillation or dual defibrillation. I have been asked to present on this topic in Criticare 2024, and during that preparation, I had learned a lot of new things which I was not aware before this. So, we'll start with the case. It's a 60-year-old gentleman with a background of ischemic heart disease, dilated cardiomyopathy, and was on beta blocker, aspirin, and statin as his chronic medical management. He has intermittent history of intermittent non-sustained ventricular tachycardia, for which he was supposed to get implantable cardiovascular defibrillator. For that, he was got admitted to the hospital, and suddenly during his hospital stay, he developed cardiac arrest. CPR was started as per ACLS protocol, and we did an ECG. This was a 12-lead ECG that was done, and it shows a ventricular fibrillation. So shock was given as per ACLS protocol. Even after giving three consecutive shock, it was not converted to sinus. Along with that, we are continuing with CPR and adrenaline according to the ACLS guidelines. But the point is, can you do anything more in this situation to improve our defibrillation success? By definition, this is called refractory ventricular fibrillation. So, if I define refractory ventricular fibrillation, it is a ventricular fibrillation that does not convert with three or more single defibrillation attempts. The estimated incidence is 0.5 to 6 per 1 lakh of the population. Around 10 to 25% of the cardiac arrest cases could develop refractory ventricular fibrillation or recurrent VF. Though the number is small, but its clinical impact can be very high because patients who develop recurrent ventricular fibrillation during their cardiac arrest has a mortality up to 97%. So this is significantly high mortality in this subgroup of patients. If you go back and try to understand the electrical therapy in case of different arrhythmia, there are two types of modalities are there. One is cardioversion, one is defibrillation. Cardioversion is the delivery of the delivery of energy which is synchronized to the QRS complex. On the other hand, defibrillation is a non-synchronized delivery of shock that is randomly given within the cardiac cycle. During cardioversion, we try to sync with our QRS complex. If it is unsynchronized and there is electrical activity fall on the T wave, it can cause something called RNT phenomena. This can create a re-entrant type of arrhythmia. In 1956, alternative current was first used for transthoracic defibrillation for the treatment of VF. In 1962, direct current was used for the same purpose, and in the early 1960s, after this initial experience, electrical countershock was used for different cardiac arrhythmias as per treatment. If we look at the electrophysiological principle of these two modalities, as I mentioned, cardioversion is a synchronized shock. What we'll do, it will depolarize the tissue involved in a re-entrant circuit, and it terminates those arrhythmia resulting from a single re-entrant circuit like atrial flutter, AVRT, AVNRT, or monomorphic VT. On the other hand, in case of defibrillation, it's a very persistent rhythm, and as a result, we need a much higher amount of energy to convert the whole atrium or whole ventricular myocardial depolarization. So there are two physiological concepts. One is called critical mass hypothesis, where we understand the entire myocardium must be uniformly depolarized to terminate the arrhythmia. And as I mentioned, we need a very high defibrillation energy. The second understanding is called upper limit of vulnerability hypothesis. Because we know whenever we are giving a shock to stop any fibrillation, they can generate new defibrillation. And the shock threshold for inducing defibrillation is less than the shock strength for stopping a defibrillation. So we have to give shock or deliver energy above a certain level so that the defibrillation will stop and no new fibrillatory wave will start. There are basically three types of defibrillation. First one is most commonly used in our practice, which is called energy-based defibrillation. Here the device charges a capacitor to a selected voltage and delivers a pre-specified amount of energy. Here, the amount of energy that is delivered up to the myocardium will directly proportional to the selected voltage and the transthoracic impedance. There can be another mechanism called impedance-based defibrillator, where the selection of transthoracic current is based upon the transthoracic impedance, and the delivery of the current or energy is stable. What they usually do, they usually assess the transthoracic impedance by giving a test pulse. Our third is called current-based defibrillator, where a fixed dose of current is delivered. The defibrillation threshold and the success in this case is independent of the transthoracic impedance, and it also needs a considerably less amount of energy to achieve its target. Out beside it, we are aware of monophasic and biphasic waveform, depending on the direction of the current. In monophasic waveform, current moves in one direction, and in biphasic defibrillation, current moves in both directions. Though monophasic defibrillation has a significantly high success rate, but biphasic defibrillators are better in terms of termination of arrhythmia. They terminate arrhythmia more consistently and at a lower energy level. Now, to understand the causes of defibrillation failure, we need to understand what are the factors that can affect defibrillation success. It can be device related, it can be related to the energy delivered, or patient related. For device related, electrical electrode position is a component, whether it is anterolateral or anteroposterior. Electrode size and optimal electrode size should be used, and which is around 12.8 centimeter. When you compare between handheld and adhesive patch of defibrillator pads, handhelds are better because of better skin contact. What are the factors related to energy delivery? It is the number of joules. Incremental joules are used in case of failure. So we now understand that with a higher delivery of the joules, success of defibrillation is better. And also the type of waveform that has already discussed, that biphasic has a higher success rate compared to monophasic, and also in terms of energy requirement. For patient-related factor, transthoracic impedance is most important. Whenever we are delivering a certain amount of current, a significant amount of energy will be dissipated for the transthoracic impedance. It's around 90%. Some amount will be dissipated to the lung, and only 4 to 5% will deliver to the heart. And when you with a recurrent shock, it has been seen that transthoracic impedance decreases and a better electrical delivery happen to the heart. Along with this, type and duration of arrhythmia are also important factor for defibrillation success. When you compare between anterolateral and anteroposterior electrode placement, as I already mentioned, the outcome is variable. But it is recommended that whenever there is a unsuccessful attempt, we should relocate electrode to the other position. This is called vector changing model. So whenever we are using anterolateral lead position, it has been seen the vector line of the electrical pulse does not pass through the posterior wall of the left ventricle, which is a significant volume mass of the ventricle. And as a result, my ventricular fibrillation can be persistent, or defibrillation can be unsuccessful. And when you put the anteroposterior electrode, multiple studies have shown that less amount of energy is required and a higher success rate as can be achieved. One of the studies involved 301 patients when sinus rhythm was restored with nearly 87% cases of anteroposterior and 76% cases in anterolateral. The mean energy requirement was also less with anteroposterior, that is 237 joule compared to 287 joule. This is the lead placement, the pad placement in case of anterolateral and anteroposterior. Now come to our today's topic of the electrical delivery, that is dual defibrillation. So by definition, it is application and administration of transthoracic electrical currents from two defibrillator devices to a single patient. But before looking at the possibility or exploring the scope of treatment with this modality, we need to understand that as per American Heart Association Guideline 2020, the usefulness of double sequential defibrillation for refractory shockable rhythm has not been established. So my point is, this is still not a standard of care. We have to use it judiciously in case to case basis according to our clinical judgment, not a standard of care. So, what are the indication? Refractory ventricular fibrillation is the great main indication. In an refractory ventricular fibrillation is the ventricular fibrillation that does not convert in response to three or more fibrillatory attempt. I'm already mentioned. What are the contraindications? There is basically no relative or absolute contraindication. Even patient who is having a pacemaker or implantable automated defibrillator can be used and should not be leave away. What is the proposed mechanism? So first mechanism is called power theory. What it means that higher energy that has been delivered in one defibrillation and when it's been repeated in the subsequent defibrillation, it allows higher success rate and higher chance of conversion of all myocyte out of refractory ventricular fibrillation. And as a result, two electrical currents from both defibrillator devices to be administered at the same time or at a close together interval. This is called double simultaneous defibrillation because both electrical current or shock given nearly together. Next principle is called setting up theory, which is applicable for double sequential defibrillator, which is more common. Here what happened, it has been shown the first transthoracic current that has been provided, it decreased the defibrillation threshold as it decreased the transthoracic impedance, and as a result, the success rate, chance of success with the second transthoracic current is higher. But we have to keep a deliberate pause between these two. Studies have also shown that if you keep pause between two successful defibrillation to around 2 to 3 minutes, it is better than 10 to 30 seconds in terms of further success. So double sequential defibrillation we'll see is more common in practice. Third is the call multiple vector theory. It has been already discussed that whenever we are giving electrical current into different axes, so the chance of success will be higher because it will cover a broader area of myocardium. But at the same time, must admit that there is no evidence suggesting that one of the intervention is better than other. In terms of personnel, it can be done by 1 or 2%. One doing with 1% is better because when one person is doing, there will be some amount of pause between these two shock, which is physiologically needed. When 2% is done, who is doing, sometimes the gap cut usually decreases and it becomes a simultaneous defibrillation rather than sequential. This is the pad placement. First set of pads should be placed as per convention, that the right parasternal and apical region. Second set of pad can be set just lateral or medial to these pads or anteroposterior to this pad. The point need to be remembered that one pad should not touch other. In that case, there can be damage to the machine or defibrillator machine. Now, what is the evidence? There are multiple case reports present in this regard, but very limited RCTs or retrospective analysis. This is one retrospective analysis pilot study where they have looked at the data from 2016-17. 2016 is the pre-phase time when the conventional defibrillation is used, and in 2017 the double sequential simultaneous defibrillation was used. Primary outcome was survival to hospital discharge. Secondary outcome was survival to hospital admission and good neurological outcome at 12 months. It has been evaluated by modified Rankin scale. 38 patient was included, 21 in conventional and 17 in dual sequential, dual simultaneous. It has been shown that dual simultaneous group had a higher survival to admission compared to conventional one, and also there is a trend towards higher survival to discharge with dual simultaneous one. And in terms of neurological outcome also, there is a trend towards good neurological outcome with dual sequential. But it's a retrospective study. We have only one prospective randomized controlled trial, which is called Dose VF trial, published in NEJM 2022. They look at the defibrillation strategy for refractory ventricular fibrillation. As I mentioned, it's the first randomized controlled trial in adult patients. It's a cluster randomized trial with crossover conducted in 6 Canadian paramedic services in the out of hospital cardiac arrest. Patients remaining in VF after treatment with an advanced life support and 3 consecutive standard defibrillation attempts were included. And the further treatment was provided by standard defibrillation, dual sequential defibrillation, or vector change defibrillation. Primary outcome was survival to hospital discharge. Secondary outcome was ventricular fibrillation termination, ROAC, and survival with good neurological outcome. They include total 405 patients, nearly 33%, 33% each in each group. It has been shown that survival to hospital discharge was higher with dual sequential and vector change group compared to standard one. In terms of neurological outcome, dual sequential defibrillation showed a higher proportion of good neurological outcome with a relative risk of 2.2 times. So to conclude, I think dual defibrillation technique need to be explored in coming days, specifically in case of refractory ventricular fibrillation. It is physiologically justified, and whatever the data we have till now is positive. Still, it is not a standard of care, but I think we have to use them judiciously in case to case basis. I just like to conclude my presentation. Thank you.